And so, of course, we've gone on to look at advance in the clinic, and we have our RANGER registry. This is a registry study, and it is the largest multi-center clinical study of peripheral nerve that's ever been done. This has greater than 2,100 nerve repairs. We're now over 2,500 nerve repairs that are in that registry. And it was started in 2008, and then in 2013, we added the match study arm, and what this does is it added outcomes from patients repaired with autograft or conduits, and we did that so we could start to make some comparisons between outcomes from allograft and outcomes from autograft and conduit repairs. And then we've also recently added our Sensation Now study, which is, or our Sensation Now study arm. And that study arm is dedicated to looking at breast neurotization outcomes. And then we have our RECON study, and our RECON study was a prospective randomized study of Avance versus conduits for digital nerve injuries. And it was limited to a gap length of 5 to 25 millimeters. And this was our pivotal study to support our BLA submission. So this was required by the FDA in support of that BLA. And in case you don't know the terminology, IND is investigational new drug, and BLA is the biologics license application. And we are transitioning Advance from being a tissue product to being a biologic, and that was done at the direction of the FDA. So we do have more than 10 publications that have come out of our RANGER registry, and the overall meaningful recovery rate that we've seen in these studies has been very consistent, and it ranges in the 82 to 84% meaningful recovery range. And here are just a few more publication results. Some of these are from the RANGER registry. Some of these are not. The Zuniga paper is from the OMF literature. But what this demonstrates is just when we're looking at meaningful recovery thresholds, we see, pretty consistent results in the 80%, 90% range. And then what we've started to do in these studies, in some of the more recent studies especially, is to always look at a higher threshold of meaningful recovery. And in what this means is, for meaningful recovery, for sensory or motor, we always base that on the MRCC scale. And for sensory, it's based on 2-point discrimination. So the better your 2-point discrimination is, the higher MRCC score you're going to have. And for motor recovery, it's based on, obviously your motor function. But what they base it on is movement. But the threshold that historically has been considered meaningful, which is M3, simply means that you can move your arm against gravity. But if you think about that, is that really meaningful? M3 means you can move your arm against gravity, yes, but it means that you can't move your arm against gravity when there is any weight or any resistance. So that means that you wouldn't be able to pick up a coffee cup. And so there has been this movement, especially, like I said, for motor meaningful recovery, to really start looking at and start considering M4 as meaningful, or S4 or S3 plus for sensory, just because what we have typically considered to be meaningful at that lower level, really, when you look at what it means to the patient, might not be that meaningful. And so you'll see some of the more recent studies have started to report that higher threshold of meaningful recovery. So one of the things that people always ask about is allografts for mixed motor nerve deficits. You know, I think most people are convinced that allografts work well for short gap sensory repairs, but maybe aren't as convinced that they work as well for mixed or motor nerve deficits. And so this is a really great paper that presents the results from the Ranger registry of the mixed and motor nerve repairs that we have in there who have sufficient follow-up for us to be able to provide results. And you can see the meaningful recovery broken out here by gap length. And you see that, you know, it's, you know, definitely not as high as what we see for sensory in the 80s, but, you know, it is in the mid 70% range. And it's very comparable to what you see for autograft results with mixed and motor nerve deficits. And you can also see that it was broken out by nerve. And you can see that the median nerve repairs did much better than the ulnar nerve repairs. And really that's pretty typical when we look at mixed motor results. And you know, nobody has really studied this in a systematic way as to why this is. Why does the median nerve seem to recover better than the ulnar nerve? But if you think about the function of the ulnar nerve, the motor movements that the ulnar nerve controls are much more intricate than the median nerve. And so it may have something to do with that. Now, another question that we get is, you know, allografts and long gaps. Again, you know, I think most people are pretty convinced they work well in short gaps, but maybe not so convinced in long gaps. And we do have, you know, several papers that have looked at long gap repairs. A lot of it does come out of the OMF literature. Which is what you see on the left, the first paper. But you can see, again, you know, very good rates of meaningful recovery at long gaps. And again, very comparable to the results that we see with autograft. And so, you know, just to really drive home the point, you know, Avance really has consistency and reliability across a range of gap lengths. Each one of these dots on this graph is represents an individual clinical study. And so you can see across all gap lengths, very consistent, you know, in that 80% range. Whereas when you look at conduits, you see that below 5 millimeters, very consistent results, very good results below 5 millimeters. But once you get above that 5 millimeter mark, you can see just how variable those outcomes are, and oftentimes how poor those outcomes are. And, you know, to compare it to autograft, again, you know, with sural nerve autograft, that's, you know, the size available is going to depend on the patient anatomy. Whereas with Avance, you know, you can choose your diameter and your length. With the sural nerve, the endoneurial tube structure is going to be dependent upon patient anatomy, and you don't really know what you're getting because there's no really good way to check that in the OR. Whereas with Avance, you know, it's controlled by quality testing. You know, with for Schwann cells, for sural nerve autograft, they are transplanted with the graft. But with Avance, we know they migrate into the graft. We've seen that in the preclinical studies. For sural nerve autograft, to remove the growth inhibitors for nerve regeneration, it occurs as part of Wallerian degeneration. But with Avance nerve graft, it's pre-degenerated and those growth inhibitors have already been removed. And as far as meaningful recovery goes in the literature, what we've seen is that the results are very, very comparable. And you know, with sural nerve autograft, you have to worry about donor site complications, which have occurred at a rate in the literature reported between 20 and 30%, and that isn't a concern with Avance.